The column has a name inside the agency. It's called the In Custody Death Notification Log, and in fiscal year 2025, it grew faster than at any point in the 17 years ICE has been required to publish it. Human Rights Watch counts at least 13 deaths between October 2024 and June 2025 across facilities operated by ICE, Core Civic, the GEO Group, and a cluster of county jails under intergovernmental service agreements. The agency's own posted figure trails that count. Watchdogs say it always does. The gap is not an accident of paperwork. It's a definition problem. ICE counts a death as in custody only when the detainee dies while physically inside a detention facility or under direct ICE supervision at a hospital. A detainee transferred to a community hospital and formally released from custody hours before he dies does not appear in the log. Neither does a detainee who dies within days of deportation from injuries he sustained inside the facility. Human Rights Watch, the American Immigration Lawyers Association, and the ACLU's National Prison Project all run parallel counts using FOIA productions, family interviews, and coroner records. Those counts run higher than the official one, sometimes by 30%, sometimes more. Start with capacity. In January 2025, the average daily population in ICE detention sat near 39,000. By April, it crossed 47,000. By the first week of June 2026, it stood at a record 58,400, the highest in the agency's history, driven by a congressional supplemental that raised detention funding from $3.4 billion to $5.1 billion in a single appropriation cycle. The beds came online faster than the medical contracts behind them. That's the whole story, compressed. ICE Health Service Corps, known internally as IHSC, directly staffs only about 20 of the more than 140 facilities holding detainees on any given night. The rest rely on private contractors, WellPath, NAFCare, Core Civic's in-house clinical division, or on county jail infirmaries operating under standards written for short-term local inmates, not federal detainees who may be held for months. The standard ICE invokes is the 2011 Performance-Based National Detention Standards, or PBNDS. It requires a medical intake screening within 12 hours of arrival, a full health assessment within 14 days, and a sick call response within 24 hours of a written request. During the surge, all three timelines started slipping. Consider Stewart. The facility, run by Core Civic on a per diem contract paying roughly $68 per detainee per day in 2025, was built for 1,752 beds. By March, it was holding 1,948. The medical unit was staffed for the original number. A licensed practical nurse working a 12-hour shift was responsible, on paper, for sick call review across 3 housing pods of roughly 200 men each. In practice, detainees reported written requests sitting in pod boxes for 4, 5, 6 days. One man interviewed by Human Rights Watch said he submitted 3 slips for chest pain over 11 days and received a response on day 12, an ibuprofen tablet handed through a slot. He survived. Others did not. The pattern that emerged across the surge facilities is monotonous in its specifics. A detainee reports a symptom. The symptom is logged, or it isn't. A nurse triages by paper, not by physical examination. A doctor, often working remotely via telehealth from another state, reviews charts in batches. By the time anyone lays hands on the patient, the window for intervention has closed. Sepsis, pulmonary embolism, untreated hypertension cascading into a stroke, diabetic ketoacidosis in a man whose insulin schedule was interrupted during a 4 a.m. transfer between facilities. That last case has a name. Jesus Molina Vea, 42, a Honduran national held at the Torrance County Detention Facility in Estancia, New Mexico, operated by Core Civic under a contract with the U.S. Marshals Service that subleases beds to ICE. He arrived on a Tuesday. His intake screening flagged type 1 diabetes and noted his daily insulin requirement. He was transferred to a different pod on Thursday. The transfer paperwork did not move with him. By Saturday morning, he was unresponsive. The facility's own after-action report, obtained through litigation, describes the cause as delayed administration of prescribed medication. That is one way to put it. He was 42 years old. The Torrance facility had been the subject of a Department of Homeland Security Office of Inspector General memorandum in March 2022, recommending its immediate evacuation due to staffing shortages and infrastructure failures. ICE rejected the recommendation. By 2025, the facility was holding more detainees than it had when the OIG first sounded the alarm. The same memo, the same building, a larger population, and a fresh column in the death log. Why do facilities under documented warnings keep receiving detainees? The answer is contractual. Intergovernmental Service Agreements, or IGSAs, the legal instruments that bind ICE to county jails and private operators, are extraordinarily difficult to unwind. Cancellation triggers per diem guarantees, severance for displaced staff, and in some cases, lawsuits from local governments dependent on the revenue. Lumpkin County, Georgia, population roughly 1,100, derives a substantial portion of its municipal budget from Stewart. Estancia, New Mexico, derives most of its operating revenue from Torrance. Closing a troubled facility is not a medical decision. It's an economic one. The economy almost always wins. The contractual architecture goes deeper. Most IGSAs include guaranteed minimums, clauses requiring ICE to pay for a baseline number of beds whether or not those beds are occupied. At Stewart, the minimum was 1,600. At Torrance, 714. The agency pays for empty beds. The contractor has every incentive to keep them full. When capacity rises above the guarantee, as it did across nearly every surge facility in 2025, each additional detainee becomes pure revenue against fixed medical overhead. More bodies in the pod, the same nurse on the floor, the per detainee margin widens. This is not a bug. It is the contract. The surge also reshaped transfers. ICE Air Operations, the agency's charter aviation arm based out of Mesa, Arizona, operated through contractor CSI Aviation and subcontractor Global X, ran 1,564 domestic transfer flights between October 2024 and May 2025, up from 982 in the prior period. Each transfer is a moment of medical risk. Medications are inventoried, packed, often lost. Charts are scanned to a system called eClinicalWorks that does not always sync across facility networks. A detainee with a stabilized treatment plan in Texas can arrive in Louisiana as a medical stranger. The intake nurse on the receiving end starts from zero. Sometimes she has 6 hours to clear 100 new arrivals, sometimes less. Think about what that means. A man with a heart condition, a prescription, and a documented treatment plan can be reduced, in the course of a 4-hour flight, to a name on a clipboard and a question mark. Then he is handed a thin mattress and told to wait for sick call. The death surge drew its first courtroom challenge in February 2026 in the Southern District of California, where attorneys for the Southern Poverty Law Center filed a class action complaint on behalf of detainees held at the Otay Mesa Detention Center, operated by Core Civic under contract with ICE's San Diego field office. The complaint, captioned Doe versus Nome, alleges systemic violation of the Fifth Amendment's substantive due process protections through deliberate indifference to serious medical need. Lead attorney Eunice Cho, who has spent 11 years inside these cases, named 7 deaths in the filing. She named 4 more in an amended complaint 2 months later. The government moved to dismiss. The motion was denied on April 30, 2026, by Judge Kathy Ann Bensavengo in a 31-page order that quoted IHSC's own internal audits back at the agency's lawyers. The audits were what ICE could not maneuver around. In discovery, the plaintiffs obtained a 2024 internal review conducted by the Office of Detention Oversight, ICE's own inspectors, who had toured Otay Mesa and documented sick call backlogs averaging 11 days, expired medications in the dispensary, and a contracted physician who had not physically examined a detainee in 4 months. The review was marked for internal use. It was never published. It surfaced because a paralegal in San Diego knew which FOIA exemption code to challenge. This is where the operational story sharpens. ICE knew. The inspectors who work for ICE wrote the warnings. The warnings traveled up the chain. The chain did nothing, or did something but not enough, or not fast enough. By the time the warnings became public, the population at Otay Mesa had grown by another 400 detainees. The system worked exactly as designed. That's the problem. Inside the litigation file, one exhibit stood out. A single page from the Otay Mesa pharmacy log dated November 11, 2024, showing 14 prescriptions for chronic conditions, hypertension, seizure disorder, HIV antiretrovirals, marked as unavailable, reorder pending. The reorder date next to each entry was blank. The same page reappeared, photocopied, in the December log, and again in January. The medications were not late, they were simply absent month after month in a facility holding nearly 800 men. When plaintiff's counsel asked the contracted pharmacy vendor in deposition who was responsible for tracking unfulfilled reorders, the answer ran 4 sentences and identified no one. Responsibility had been distributed until it evaporated. The decisive moment came on May 14, 2026, when the House Appropriations Subcommittee on Homeland Security held a hearing in Rayburn 310 that had been scheduled for routine oversight and instead became a forensic accounting of the death surge. Acting First CE Director Caleb Vitello sat at the witness table for 4 hours and 12 minutes. He was asked repeatedly whether the official death count matched the count compiled by outside researchers. He said the agency stood by its numbers. He was asked whether the agency tracked deaths occurring within 72 hours of release from custody. He said it did not. He was asked whether IHSC had sufficient staffing for a 58,000-bed system. He said the agency was actively recruiting. The room understood what those answers meant. Recruiting is not staffing. A target is not a nurse on a floor. 3 days later, on May 17th, the Department of Homeland Security announced a medical surge initiative, 60 additional IHSC clinicians, expanded telehealth contracts with a Texas-based provider called Access Telecare, and a new internal reporting requirement that any death within 7 days of release must be logged in the in-custody death notification system, regardless of formal custody status. The reform looked like an answer. It was, in part, a redefinition. By widening the definition, ICE acknowledged that the existing count had been narrow. Watchdogs called it a tacit admission. The agency called it a process improvement. Whether the new clinicians actually arrived is a fair question.
60 positions were posted. As of mid-June 2026, 23 had been filled. The hiring pipeline for federal medical staff runs 6 to 9 months under normal conditions and longer for facilities in remote locations. Lumpkin, Georgia, is a 4-hour drive from Atlanta. Estancia, New Mexico, is an hour from the nearest hospital with a cardiac catheterization lab. The market for nurses willing to work 12-hour shifts inside a detention facility for federal pay in a town with no grocery store is thin. It was thin before the surge. It's thinner now. Telehealth was the agency's preferred answer to the geography problem. Access Telecare's contract, valued at $42 million over 3 years, promised on-demand specialist consultations through tablet devices in facility medical units. In practice, the tablets required broadband connections that several rural facilities did not reliably have. At the LaSalle ICE Processing Center in Jena, Louisiana, the unit was offline for stretches of 48 hours at a time in February and March 2026, according to maintenance logs released under state public records law.
A cardiologist on a screen is not a cardiologist on a screen if the screen is dark. The Surge Initiative had purchased the appearance of access. The substance lagged by a connection bar.
One more set of numbers. The cost of a single in-custody death, measured in litigation settlements alone, averaged $1.2 million across the cases ICE settled between 2018 and 2024. The cost of a full-time IHSC-registered nurse, fully loaded, runs roughly $145,000 per year. Written on any whiteboard, that math suggests staffing is cheaper than dying. But the math is not the operational reality. Settlements come from one budget line. Staffing comes from another. The agency that pays the lawyers is not the agency that hires the nurses. That's how a system can know the answer and still produce the wrong one. By the first week of June 2026, the detention population stood at that record 58,400. 17 detainees had filed grievances citing untreated medical conditions in the prior 30 days. 3 had been hospitalized. 1 had died. His name was Rodrigo Ayala Perez, 31, held at the South Texas ICE Processing Center in Pearsall, Texas, operated by the Geo Group. He had reported abdominal pain for 6 days. The autopsy, performed by the Bexar County Medical Examiner, listed the cause as a ruptured appendix complicated by peritonitis. The condition is among the most treatable emergencies in modern medicine. A community hospital handles it in under an hour.
It killed him over the course of a week in a building with a medical unit, 50 miles from a city of 1.4 million people. His family learned of the death from a consular officer at the Mexican consulate in San Antonio, not from ICE. The notification call came 18 hours after he was pronounced. His mother, reached later by a reporter at a Spanish-language daily in Monterrey, said she had not known her son was sick. He had called her the previous Sunday and told her he was fine. He had not wanted to worry her. In the recording of that call, which the family later shared, you can hear him pause mid-sentence and exhale slowly, the kind of breath a person takes when something hurts and they are deciding not to say so. He was 6 days from the end of his life. The medical unit was 40 steps from his bunk. Return to Stewart, to bunk 14, to the flashlight at 3:14 in the morning and the sick call slip in the wire basket 50 feet away. The man in the bunk had a name too. He had been in custody for 41 days. His sick call slips, 3 of them, were dated April 18th, April 21st, and April 24th. The flashlight found him on April 27th. The basket was emptied on April 28th, the day after he died, by a clerk who later told investigators she did not know whose slips she was filing. A clerk emptying a basket of requests from a man already in a morgue. That detail is the entire operational story compressed into a single gesture.
The system has a process. The process has a paper trail.
The paper trail moves slower than the body it was supposed to protect. The deaths are not anomalies of the surge. They are its arithmetic. And the count, whichever count you use, is almost certainly still low. The next quarterly in-custody death notification update is scheduled for posting on July 15, 2026. Human Rights Watch has already begun assembling its own version. The two numbers will not match. They never have.